Thank you. Hi. Um, which way's forward that one? Hi. So my name is Beth Ann. Like Catherine said, my research is adapting the eye support intervention for dementia carers. And I'm going to explain my project, but this talk is specifically about the importance of person-centered research. So when I say person-centered research, I mean being as flexible as we possibly can for the participants so that they can take part, because involving dementia carers and people with dementia in research is so important. So Catherine's already said all of this. I have a background in psychology, and then I went to work for 3 years in an EMI nursing home. I hate the phrase EMI, but it does explain that most of the residents had dementia. It was an amazing experience, a bit of a roller coaster, but from talking to the people with dementia and the carers, their families, they have next to no understanding of what dementia actually is. So that's where my PhD comes in. I'm in my 3rd year, and I've got a photo there of me looking very uncomfortable next to a poster at a conference. So iSupport. iSupport is an online training resource for carers of people with dementia. It was created by the World Health Organization, based on CBT and person-centered care principles, but it was created for the more common types of dementia, so Alzheimer's and vascular dementia, which typically affect older people and their memory-focused dementias. It was created to be adapted and translated for other cultures, languages, so that it has a wide reach globally. And it's currently being adapted in 39 countries, including Portugal, India, Australia, Brazil, and Switzerland. And then here in Bangor, we've got a Welsh translation. There's an adaptation for young carers. There's my rare dementia adaptation, and then there's a large feasibility trial for the English version. So like I said, I'm adapting it for rare dementias. I am talking about specifically frontotemporal dementia, which affects behaviour mainly. Posterior cortical atrophy is vision. Primary progressive aphasia is a language dementia, and Lewy body dementia is movement and hallucinations. They obviously have more symptoms, but those are like the key ones for each diagnosis. I'm working with the Rare Dementia Support charity. They offer support for carers and people living with rare dementias, as well as training opportunities for healthcare professionals, and I'm recruiting through them as well. So my adaptation is needed because obviously they have different symptoms. They also often have an earlier onset than other dementias, so below the age of 65, meaning that they will need different levels of support. They might still be at work, have younger children. There's different needs there. So the WHO created the generic version so that it's easily adaptable for other countries to increase its reach. So you have to apply to the World Health Organization for a license, and they'll send you an adaptation handbook, which will tell you how to adapt it. And there are 3 steps. You have to hold focus groups with informal carers and healthcare professionals to discuss the type of changes that they want to see. You need to send those changes to the World Health Organization for approval, and then pilot the adapted translated version. So the plan was to use a nominal grouping technique, which is an in-person consensus tool for group discussions. I was going to use this for my focus groups. There are 5 steps. The introduction is where I would introduce the research question and discuss what's going to happen throughout the session. Then there's silent idea generation. So everybody thinks about their answer to the research question and writes it down. And then we'll go around in a circle, and everybody will share their ideas until they're all written on a whiteboard at the front. They're given the opportunity to expand on their ideas and explain anything that isn't clear. And then anonymously, everybody will vote for the ideas that they think are the most important. So these will be the changes that they want to see in the new adaptation of iSupport. So that was the plan. The problems, COVID. So I started in 2020, which was an issue. In-person focus groups were not going to happen because of COVID. You can't meet in groups, and carers and healthcare professionals have a lot of contact with clinically vulnerable people, potentially clinically vulnerable, so that wasn't going to happen. Traveling, they might need someone to look after the person with dementia, which again is an issue. Childcare, taking time off work. And they're very, very busy people. Healthcare professionals and carers are very busy, and caring is and should be the priority. So to overcome this, everything was moved online. I sent support to them online, and they were asked to do everything from the comfort of their own home. So we gave them the option of providing their feedback using online semi-structured interviews, online focus groups, or via email. So I used a modified nominal grouping technique following the same 5-point structure, but again, it was all online, and it was more flexible to enable these very, very busy people to actually take part. So the introduction was done via email or on Zoom. I asked the research question, and I sent them a PDF version or a paper copy to their house. And then the silent idea generation, they were given 2 weeks with iSupport to write down the changes that they wanted to see. The round robin was the data collection via online interviews, focus groups, and email. And then the group discussion wasn't a group discussion, but they were invited to expand on their ideas using the interviews, groups, email. And then prioritization, everybody anonymously voted for which ones they thought were the most important. So there's obviously an issue with that. The people that were giving feedback individually weren't able to vote for the ideas that anybody else had put forward. So I added an additional step there. I sent the draft version of iSupport after having made the changes. I sent the draft version of iSupport to them along with a little questionnaire to see whether it was what they expected, what they wanted to see from the focus groups. And this was based on another study that created an intervention for carers of people with cancer. For their validation step, they had a 5% response rate. I got 40%, which I mean, still isn't great, but it's not 5. So recruitment, like I said, it was done through the Rare Dementia Support Charity. I got 9 healthcare professionals and 6 informal carers to take part. 87% of them were female, which is probably representative of the population. As we all know, it's mainly female. I'm not going to go into huge amounts of detail about the results because there were 212 adaptations that were suggested, and I can't talk about that. Okay, so I need to speed up. We made 92% of those changes, and this pie chart is on the prioritization exercise. So I compared the 2 groups, the healthcare professionals and the informal carers, to see whether they prioritize the same changes. It's mostly agreement, but as you can see, there's more than a quarter of the changes they disagreed with as to their priority. This is the results for the new validation step. They agreed with most of the changes. I think it's cut off the bottom, but the orange is strongly agree that the new version is an improvement. The green is somewhat agree, and then the yellow is neither agree nor disagree. So none of them disagreed that it was worse, which again, winning. So there are challenges of involving people with a lived experience, obviously, incredibly busy. I'm going to power through these because I'm going too slowly. Yeah, they're too busy. There was adapting the methods, which was difficult. Recruiting through a larger pool, respondent fatigue was a potential reason why I only got 40% to respond to the validation step. Benefits, as you can see, I think the benefits vastly outweigh the challenges because there's a table here. And they have invaluable information that nobody else has. Nobody knows how to adapt iSupport better than people who have lived experience. There's unique perspectives. The term pleasant activities is used throughout iSupport. They hated it. I didn't realize that it was patronizing, and obviously nor did the creators of iSupport, but without their input, we wouldn't have changed that. The flexible methods are more person-centered, which is in keeping with the principles of iSupport. The participants were just so enthusiastic. They really wanted to help. And then for me as a researcher, I've learned about rare dementias from people who know them better than anyone. My problem-solving abilities are improved, my organizational skills are improved, and I got to talk to some really interesting people. So this is the last slide. I've got some feedback from carers that I think just drives home the importance of person-centered research and including people with the lived experience. So someone said about iSupport, I do doubt whether it was written by anyone with any true caring experience. Someone else said, thank you for taking comments and adaptations on board. So she was just so enthusiastic about taking part. And then the second one was a carer who was meant to come to a focus group, but didn't, and then was meant to come to an interview again, but didn't. And I was about to say, can we do it by email? And he said, can we have one more try at an interview? And when I agreed, he said this, he really appreciates my patience. I do have some comments on iSupport that I really want to share, but my wife was having a bad day. So any frustration that I had that I got stood up twice was just, this just reinforces everything that they're doing, the importance of person-centered research and involving these people who have such valuable experience. And that's it. Thank you. Are we doing questions now or after? Yeah. Okay. Yeah.
Just on the floor, and we'll see if we can see any in the chat as well. But thank you, Becca, for that great talk.
Thank you.
Let's see if we've got questions coming in the chat. Welcome, Hannah. Welcome, Dory. Nice to see you. Thanks to British Rail, we've got more speakers coming in. Right. So Ian's got a question.
You had to change your methods because of COVID.
Yeah.
You had to change how you do it. If you could start again, would you use your original methods or would you do what we did?
I think I would do what I did because of the time constraints, like in terms of caring. I managed to widen the recruitment to the whole of the UK. So I had people from Oxford way and all sorts, and I don't think they would have travelled to Bangor if it was in person. So I think I would have done it online.
That's really good because I think it's actually another finding as well as to say how you actually do that kind of research in a different place.
Yeah.
It's not just the hypothesis, methods findings as well are really good.
Thank you.
Carers. Do the carers who don't have computers get to know what's being said online?
They all have computers. Everybody in the Rare Dementia Network, they take part in online focus groups and things. So everyone I recruited did have a computer.
Well, some carers don't have computers and don't even understand computers. So
Yeah.
I don't know if I was a trustee with Carers Outreach in Bangor at one time. So
Yeah, so we've had a few technical hitches. I'm in the feasibility testing stage of it, and there have been a few people unable to log in and technical issues that way. So it's a finding. It's something for me to discuss and then think about in the future. And the main iSupport trial that Jill is running, thinking about ways on how to disseminate it. And yeah,
it's difficult.
Yeah, thank you.
There is a book that's available as well.
Yeah, the PDF version.
So
Yeah,
you can get a paper copy.
Well, that's good. And just to repeat, because Jill Windle was just emphasising that at the end of the study, there will be a paper copy available for people who haven't got access on the internet, which is a great range of opportunities for helping carers, isn't it? Yeah. So well done, Bethan. Thank you very much. Thank you for going first. Very brave. Bye.
Catherine, sorry, we have a question from online.
Okay, thank you. So what's the question? Can you shout out because I can't see it?
So John Gallagher says, did people know about the iSupport before you made contact? Is it known about in Wales?
Sorry, John.
no, I don't think so. There was a few people that I approached who had taken part in Jill's feasibility trial. So they knew about it in that respect, but my adaptation is very new, so nobody really knew about it. And it's still, the feasibility trial is one of the very first, so the iSupport as a whole is still in a very early stage of testing.
When did the first I support with the WHO come out? Is it
Was it
is it quite recent?
2017?
2018.
Oh, right, 2018, so it is very new, really, internationally, isn't it? Yeah.
Yeah.
And Wales are leading the way in adapting it to be more culturally appropriate for people. Yeah, lovely. Thank you. Great. Thanks for the question, John, and thank you for shouting out from Swansea on his behalf. Lovely. Right. Who have we got next?
Hey,
Hold on. Hold your horses, Graham. Graham is really itching to get going. So Graham Hayes is an ex-speaker, and he's taking part in research that's very close to his heart as a resident in lovely Shropshire. So he's in his second year of his PhD here with us at Bangor University, and this is following a very varied career, but mainly working in education in schools as a teacher, head teacher, and as an educational consultant. But in his retirement, Graham decided that he wanted a new challenge, and alongside being a husband, father, grandfather, hill walker and volunteer, he's decided to use his experiences and interests to find out more about the role of rural community in facilitating older people to age well through their own eyes. So welcome, Graham, and I'll let you tell us your story about your research and how you've gone about it. And Jonna will help with the timing of the slide here.
Thank you. Welcome to a PhD journey that started with a light bulb moment. That's me, that's where I'm at, and this, I believe, is where we are today. The journey from the light bulb moment to today really got going in the lockdown period. Do you remember lockdown, that first one? The world went quite quiet for a while. Time seems to stretch out a little more at that period of time. And so the lockdown period saw a great deal of activity take place, because while we were locked down in our houses, tremendous community responses were taking place. The like of which we'd not seen before, but made you question what was going on before. So the question was, what on earth are we seeing here? Because COVID brought a tremendous amount of fear, a tremendous threat, but as we know in life, along with threat come opportunities. And for me, the opportunity was to begin to read things that perhaps I had not read before. And it was aging. There was one book, here's a confession, a PhD student read a book. Yes. The Changing Mind was the book. And what The Changing Mind did was set out what happens to the human brain as we age. This was not a page turner. However, fascinating, and I was grabbed. That was it. I was off. It was aging. Then, of course, it was aging well. And you'll be aware that there is a huge amount of information out there on how we age well. Look upon me. I am part of that process and trying to make sense of what on earth is going on at this point of time. So the question was a very general question, what's going on? And then it started to get a little more focused and get a little bit of color. Now, I don't know what your brain works, but as soon as mine actually presents a question, about 1,000 others appear at the same time. But bit by bit, one question began to get a color. And this was the question. I'd seen in my own community a tremendous amount of activity that was focused on looking after older people, because if you remember about COVID in the early days, it was people in my age group were the ones seen to be greatest risk. Thankfully, it did not affect younger people in quite the same way. So this was the question that started to roll around in my head. What role does a rural community play in helping older people to age well. In my reading, I started to discover that with the huge amount of work done on aging, and you'll be aware of the big general picture, the world's population has been increasing and the world's population has been aging. So once again, you've got a challenge, but also you've got opportunities that might result from this. Rural community, I started to find less well represented in the research that's being carried out there. A lot of research on urban areas. There is research on rural communities, but not to the same extent. Two happy older people. Every time I see that, I want to smile, and I hope it induces that in you too. Bit by bit, having contacted 4 universities in the UK that were interested in aging, I ended up here at Bangor. And after quite a lot of work, it seemed, this became the title of the study. Older people's views, people's life course. What have they done with their lives? What are they doing with their lives? What are they going to be doing with their lives? One main strand. Back to the role of community. What effect is community having on these older people to facilitate them to age well? And then in the rural context. So you can see the strands that are starting to appear here. Rurality, I think, was one of the reasons that university found this interesting. And here are some elements of the study that fit into what we're talking about today, lived experience. So I decided to use a guided interview to capture the lived experience, set up an opportunity to re-meet with those who were participating, to reflect on the transcripts of the interview and the discussions that were held, and then to the point where I am now, beginning to tease out through thematic analysis some of the key components of what the older people were talking about. And then, of course, to apply those to the research question. What's worked well and what have been the challenges? Recruitment went very well. I tended to use third party. In the community in which I live in Shropshire, a lot of groups, a lot of activities, a lot of grouping of people. So I contacted those groups to see if anybody would be interested to participate. Those two factors that worked well, both the enthusiasm and the involvement, I think actually focused back to this business of looking at people's life course. What's important to them and what can they tell us about that? Key, the reflection. My participants have told me they've enjoyed the reflection. It's made them think about things that they would not have thought about before. I thought my protocol year would never end. It went on and it went on and it went on. And the supervisory guidance went from sort of stage managers avoiding the trapdoors and the black holes of PhD study to the wonderful Narnia kind of moment where I'm transported out of one world through the wardrobe into a different world called methodology. Those two were the bedrocks to carry me through this process. Some participants did not want to meet in their home environment, so we found somewhere else to meet. Looking back through those interviews, it had an effect on the relaxation, the openness. It took a while when you're in a strange place to do that one. IT skills of participants, I don't think I was quite ready for that. Some have virtually none. Because to get into my study, you had to be 65 years or older, and you had to live in the Church Stretton, the rural community, for 5 years or more. But the IT skills were key because ended with me actually taking hard copies of the information materials to the participants, and even collecting them. Keeping to interview timescales. There it was. This magnificent beast. 12 interviews in my study with 12 remits. And you know, when you put it on a piece of paper, oh, it looks great. Oh, no, it wasn't. Because some participants needed keeping on track. Do you know, when you actually talk to people about their life course and they feel you're really interested, boy, oh boy, does it come out, and all to the good in some ways. And then, of course, you have that. Yeah, my wife has been in hospital twice since I started this off. COVID came back, and one of my participants' wives caught COVID. It wasn't even him, but that closed down that particular one. And then he went on holiday for a fortnight. See how it works? This is my best slide, because this all sounds very easy, but very trite, all carried out, no problem, get an idea of the study. That's my PhD. Okay, can you see it? Because there have been moments when the focus went. There have been moments when I felt out of my depth. I have to say also, there have been moments that I have enjoyed so much. I never thought I'd get the PhD moment at my stage of life, but I have. The grandchildren are confused, but that's a whole different story. So here it is. When it comes into focus, that's what it looks like. And I have to say, what a fantastic privilege, isn't it? To be able to take part in a higher degree, and what a fantastic privilege to be able to share other people's life story and then try and make sense of it. Thank you.
Thank you, Graham. So questions from the floor, and then we'll check the chats as well this time. So who would like to ask Graham a question? Are there PhD students or more experienced researchers? Bill.
You mentioned that for this bit of the study, you were recruited your participants through community group.
Yeah.
One of the big challenges we face in research that we often criticise of is that the people we recruit are perhaps more educated. How do you do, did you do anything to try and tackle the kind of potential inequality in your participants?
Took a lot of thinking through in the protocol stage. That, I mean, that's the whole point of the protocol, isn't it? You have all those big questions that you ask yourself. How can I avoid this? How can I make sure of that? I didn't try, if I'm brutally honest with you, because it's a community in which I live. I know some people in this community. So I went for a random approach. As it's turned out, it's quite fascinating, because I've done 12 interviews, okay? 14 people. I was interviewed by a pair of sisters. I was interviewed by a pair of sisters. You got the message there, I'm sure. The groups turned out to be pretty even, both from terms of gender. Health, I think, is the key issue that I was thinking about here, because all the people that I've interviewed state that they're basically healthy. And the way they've defined that in the conversations, Jill, that I've had with them, is that if you're healthy, you've got choices. If you're not so healthy, maybe your choices are not so great, and how that works in a community as a spin-off, I think. So yeah, it's a very good question. I wish I had a very good answer for it.
Work in progress.
Absolutely.
Another Jill Toms has got.
All right, Jill, can we go?
If you could repeat the question as well, just so that people online could hear the question. That's
Go on, Jill.
Just following on from the other Jill, do you think it's possible that people who weren't connected to local groups in the community might have thought about their community different, or had a different experience?
Yeah, I mean, even in the sample I've taken, we have a community where we have a lot of other incomers. So trying to find people that have been born and bred in that community took a bit of searching through third parties, and they have a different view. No two ways about it. But I think every time we sample, surely we're going to end up with a different potential outcome. Sorry, I didn't repeat the question.
That's okay. There is another question in the chat by John here. So did you interview any housebound people?
No. But that wasn't by choice. That's just how the sample works itself out.
Your recruitment, part of your proposal was it was developed during social isolation, wasn't it? And then with a hope that you could interview people face to face. So it's been, as we've come out of more restrictions, you've been able to see people maybe within the community, but
yeah. What I was most concerned about was that I would get inundated with people who wanted to take part, because the community in which I live tends to be that kind of community. And as soon as you've got something working within the community, they're very interested. So one of the outcomes of this research is me placing myself back into that community and offering to share the findings with this community. And I'd be very surprised if I don't get a packed hall at some point, because people are going to be fascinating to see what kind of answers they'll be looking for that maybe I won't be able to provide them with, or I will be able to provide them with the outcomes of the research.
great. Thank you very much. Thank you.
Okay.
Thank you, Graham.
Okay.
Right. How's everybody feeling? Online, do you want a bit of a wiggle at home to sort of stand up? Because we won't be able to see you. Or here in Swansea or Bangor, do you want to stand and sit? So, no, is everybody okay? Yeah? Still with us? Still the train of the PhD journey? Yeah? Great. Okay. So next, we're hopping over to Swansea. And this is a lovely opportunity to highlight a really important study by Zoe Schumacher-Sells. And I'm just give you a little bit of a background that you've got on your documents as well. Her work has focused on the challenges facing older women living with continence issues and adopts a life course approach to women's health. So really important matter that we don't often hear about, and I think it's important that we actually explore this more. Zoe will probably tell us more about the methodologies that she's adopted and the diverse relationship between long-term chronic conditions and urinary incontinence in women aged 50 and over living in the Welsh community. So I'm going to be 50 in October, so this is going to be really important for me, I think, to listen. Yeah, highlighting the opportunities for health promotion, preventing negative health experiences, and restoring health and well-being later on in life. So it's really important for at least 50% of the population to know more about this. Yeah. So thank you, Zoe, for joining us. And I'm really looking forward to listen to your talk and hear more about your experiences. Diolch yn fawr iawn.
Yeah, thank you. Thank you. Well, today I'm actually going to talk about some of my findings from my literature review. Yeah, there we go. Yeah, from my literature review. And when I began thinking about doing a PhD subject, I wanted to do it on something I knew, something that I knew people around me were experiencing. So that was why I felt there was a great need to explore the challenges faced by women living with incontinence and chronic illness. And it was this, the oops moment. Many women will have experienced this, or perhaps they've yet to go on to experience this. And I'm sure that there are perhaps some men that have experienced this type of moment. I've experienced that moment, and there's shame. And when you add chronic illness to the cooking pot, you also add fear. But finding a word that encompasses that oops moment can give you courage. how many people know that this word exists? Teasing. How many women know that incontinence should not be defined by age? When I began exploring the concept of chronic illness and urinary incontinence in aging, I began thinking about what comes first. Is it incontinence? Is it chronic illness? If we knew what came first, could we do something not just to treat incontinence, but perhaps to prevent it? So my literature review was a bit like a boxing match, over 2 rounds. And that was because when I began the literature review, I was hoping to find this rich collection of information that would highlight the association between urinary incontinence and chronic illness. And I only found 9 internationally written quantitative studies with only 3 papers exploring it from the perspective of women. And all this demonstrated was prevalence and very little else. So I did a second review. And in essence, I was just critiquing urinary incontinence and critiquing chronic illness. And when I placed this in the context of women, it felt like I was opening up Pandora's box. But only 114 articles really gave me what I wanted. I was still left with very little breadth of information, just numbers really. So the themes that I came across, and the 4 themes to my right, were from the main first round. I perhaps should have put that up there actually. Note for next time. I expected them. The 8 sub-themes, again, they're just a breakdown of the earlier themes. So, throughout their lives, women face unique challenges regarding their physical health, their interaction with the healthcare system as patients, caregivers, and family representatives. And perhaps the continued lack of representation in biomedical and health research is the reason why there is an increased likelihood of women's symptoms being attributed to the aging process rather than ill health, as women's symptoms are often viewed as emotionally based and consequently not fully attended to by our medical professionals. And as a nurse myself, I've witnessed that. I know that this is a bold statement, but the World Economic Forum states that it will take 132 years to reduce the gender parity gap. For many women, their contribution to society continues long after they retire. Their role in society can be particularly affected by the ongoing costs, access issues, and discriminatory policies. And we've all had this, seen this slide. But when you consider that there are 985 million women aged 50 and over in the United Kingdom, and that figure is expected to rise, and that by 2030, it's projected that there's going to be over 1 million older people in Wales. That's 1/3 of our total population. Simply said, there are more women using our healthcare system. Okay, not going. Oh, yeah. So life expectancy is very important. In all countries of the world since 2006, women have lived longer than men. However, here in the UK, life expectancy is falling at birth. many women living in the most deprived areas of the United Kingdom will go on to spend a third of their life in poor health, while those from the least deprived areas will spend less than 2/5 of theirs incapacitated. And you can see quite clearly it's quite shocking. And current evidence shows that the extent of this gap is different in a life expectancy of 4.5 years between the most and least deprived areas. And this is due to higher death rates for some diseases like respiratory, digestive and circulatory problems. And life expectancy gains have stalled, particularly for women. Now, have I gone too far? Yep, sorry, that's right. You can see here the chronic conditions. The midlife is a critical period in the life course, and it's when chronic conditions tend to increase and decline in physical functions become apparent. And the realities of health differ more for women, and women are more likely to develop more chronic health conditions. Approximately 85% of older adults have at least one chronic health condition, and 60% have at least 2 chronic conditions. Hagen et al. Acknowledged that those with severe symptoms of incontinence at onset had increased body mass index, were more likely to be smokers, with worse health profiles that included an increased prevalence of type 2 diabetes and a previous hysterectomy. And it's just rising. I've got a slide missing. Oh, no, there it is, sorry. How do I go back? Sorry.
No, it's all right.
Yeah, I'm fine. Sorry about that, ladies and gentlemen. So the relationship between urinary incontinence and long-term chronic conditions, it's often overlooked. And among these top 10 chronic conditions for older adults, not many people will know that incontinence is actually one of the symptoms. And why are women not being told that incontinence is a symptom? And Schlegel and Gordon, they stated, incontinence is simply getting lost in the midst of multimorbidity and frailty. There's a sense of futility. Not so long ago, it was unclear how the etiology of urinary incontinence was associated to aging. And that we're now at a juxtaposition of showing prevalence and acknowledging those multifactorial mechanisms involved in urinary incontinence, because we know that there is a systematic association between incontinence and comorbid conditions, and that the correlated risk factors are biological, socioeconomic, cultural, environmental, and behavioural in nature. And we can make changes here. Urinary incontinence is a global public health problem, and it affects women of all ages. The World Health Organization states 8% of the global population are affected in the United Kingdom. It's currently estimated that 14 million people live with bladder and bowel problems, but more than 60% of the women do not seek treatment for their urinary incontinence. Data from the Irish Longitudinal Study on Ageing demonstrated that over 40% of their female participants had reported symptoms of urinary incontinence, yet they've failed to report their symptoms to healthcare professionals, with many of their participants visiting a GP on average 4 times in a 12 months. And this is quite shocking. It is more common than breast cancer, heart disease, or diabetes, but we're not doing anything about it. So, Pandora's box, reproductive health, women's health. Are they the same thing? The relationship between these two terms is because there is an integral aspect of women's overall physical and mental health being related to their reproductive health. And what people aren't realizing is that our reproductive health is a sentinel of various long-term conditions in later life. The time between our first period and menopause is a critical period. For many women, this is a timescale of 40 years. And evidence is suggesting there is a link between early and late menarche and chronic disease risk. But are we educating our young girls? Studies have shown that multimorbidity can predict the onset of urinary incontinence. The earlier detection of chronic conditions can promote the earlier resolution of urinary incontinence, reducing the need for clinical intervention and preventing the psychosocial burden of symptoms. As you can see, there was a lack of evidence regarding prevention and treatment. There was a lack of evidence that related to the ways to improve quality of life in women diagnosed with incontinence and chronic illness. And there should be an emphasis on exploring these topics from the lived experience. Why is my study important? It's simply not been done before. Nobody has actually asked women, how do you feel? And that's what I'm going to do. Oh, sorry, I've gone too fast again. Thank you.
Thank you very much, Zoe. That's a really thought-provoking presentation and really does put a really strong argument for why this is really important for so many people internationally. Any questions? I think there might be a question in the chat. We'll start off with that one. Oh, so it's a comment from Carol Davis here. Said, well done. Thanks for raising the gender dimension of this complex issue. Are there any questions from the floor? Anybody'd like to ask Zoe a question? Yeah.
It's not an ask.
Right.
As in, I have dementia.
There you go. Right.
And I have this urinary incontinence.
Yeah.
I have brought up the subject with the GP, and it's like, it's not that I know when I need to go, the signal doesn't get through, and when I need to go then. I can't hold it at all.
Yeah, there are so many different types.
What you're doing,
Yeah. Just wanted to say there are so many different types of incontinence, and often the GPs don't recognise that. So it's about getting referred to the continence nurses and getting their support.
Yes, I did, and they did tests, so there was no problem in my bladder or anything. So it is down to my dementia. They said the signal's not getting through to my brain, that from my brain that I need to go to the toilet until I need to go.
So in a way, Zoe, if I can just follow that up, would there be, when you're going to be interviewing people, women in your study, will you be looking for certain types of other conditions that people are living with? And Teresa's point here about living with dementia and her experiences, you know, that connection with not being able to recognize that signal, is that something that you're looking at specifically?
That's a brilliant question. Firstly, there's as I said, there's different types of incontinence. So the incontinence that I'm sort of looking at is where conditions such as heart disease, diabetes, pregnancies, they've created problems in the pelvis, in the pelvic organs, and they're being exacerbated. And obviously, as you age, it all gets worse. And about how we can actually intervene at certain points across the life course and actually prevent those things happening. Now, in dementia, we know that it's in the brain, but if you've obviously got problems associated with, you know, having a weakened pelvis, having diabetes, having heart disease, those issues are going to be exacerbated. But I had to make the decision to actually remove dementia from my list of conditions because of that exact reason that, you know, in some patients, the dementia was causing their incontinence.
I think that's a good illustration of what happens when you're any researcher, is that you want to answer everything and there's only so much that you can focus on, but maybe this is an area that needs maybe a fellowship after your PhD. Yeah.
Nice.
Yeah, sorry. Another question from the floor here.
Just a quick question. So if you've got someone then with multiple health conditions, do you think it will be quite challenging to narrow down which one is actually causing the incontinence then? I just wondered if that might be a challenge.
We've recognised that there are clusters of conditions. So diabetes, heart disease, hypertension, those conditions, they form in clusters. And obviously, if you've got then a patient that's got COPD, then it is a case of trying to rule out which is which. And you might have a patient, as I said, who's got COPD, and because of the coughing, they're weakening their pelvic floor. But in patients with diabetes, hypertension, and heart disease, you often find that it's polypharmacy that's causing it, or I should say exacerbating it. It's about looking to see if in these women there are other events that have happened. Have they had pregnancies where they've delivered big babies? Have they had cesarean, not cesarean, but have they had forceps? Are they athletes? You know, this is where I go back to health education. Trampolining, it's a big no-no, not just for women of our age, but for young children, because you're weakening your pelvic floor. So yeah, it's about trying to, you know, balance all of those things really at the moment.
Well, brilliant way to end the talk, I think. A big no-no to go on the trampoline. So yeah, I won't be pulling that up to the shed then. Thank you. And I think there's a comment here from John. This term peasing should break the embarrassment language barriers many people might feel, and could be a basis for a good public health Wales awareness raising. So if you leave today's session with nothing else, share the word peasing around. Yeah. Okay. Thank you very much, Zoe. That's excellent. Right. So we are now going to have a double act, and it's going to be Hannah Jelly and Teresa Davis, aka Dory. And it's lovely to have both of you here today. Just as a brief introduction, Hannah's been a member of the team here before I even walked through the door. So Hannah's very well established in DSDC here in Bangor, and her PhD explores the resilience of people living with dementia and their carers. She's particularly interested in helping to see what can be helpful when people are impacted by dementia and improving services. And her work uses grounded theory and co-production, but don't worry if you don't know what that is. I'm sure Hannah will help us out to achieve a resilience building framework that will empower people living with dementia and their carers, which leads us on lovely to Dory, Teresa, who is the ultimate empowering person we've got in the room here today. She's an expert by experience living with dementia and a member of the CABAN group of people living with dementia as educators here at Bangor University. Teresa is a strong, positive woman living independently with a lovely dog and living with a diagnosis of dementia as well. She inspires students and people who work to support people living with dementia to change their outlook on the diagnosis and to challenge all the stereotypes that we know about so much. She's passionate that people with lived experience should direct research and has also led her own research studies within the DEEP network. And has also helped to create the Knowledge is Power booklet as well. We've got some copies here and we'll put the links in the chat to you afterwards if you want to access those online. So with those very brief words of welcome, I'm looking forward to our next double act. Chris up.
So our presentation today is a double act, isn't it? We're talking quite a lot about co-production and working together. And I've had the great privilege of working with Dory for quite some time, and she keeps me in check, don't you? You're brilliant. So let's just move on to the next one. Okay. So my PhD then is about co-creating a resilience building framework for people living with dementia and their carers. I'm the PhD student. Dory is one of my supervisors with lived experience, and I also have another supervisor with lived experience as a family carer. And then I also am lucky enough to have academic supervisors, so Jill's in the room. And I also have Sean and Jackie as well. So we're a nice team, aren't we? All working together.
We're a nice bunch.
Yeah, friendly bunch. So we wanted to just talk a little bit about the process of being a co-supervisor then, because I think we hear a lot in research about PPI and involving people with lived experiences, which Dory does a lot of, don't you, as well? You're part of the Caban group and different things that you help us with. Being a co-supervisor as part of a PhD was a little bit more involved even, I would say. So I guess just thinking about the process, for this particular project, we wanted her involvement in all stages of the process and Anne's as well. So that kind of involved this. We had to make sure that you were happy to agree to the role and be involved. And it's quite a huge commitment because you have to come up quite regularly. And there's a lot of information that we go through, isn't there, which I think is very tiring at times.
Well, I find if you looked after, if it's the right people, and I must say here at Bangor, they do make it easy and uncomplicated as much as you can. You know, the train was late, but
sorry about that.
You can't do anything about that. And I'm really grateful, and I think a lot of other people living with dementia who are involved as well, that we're asked our opinion and what we think of the work you're doing, because it'll be what involves us, what we want, and what we can do, and you help us to do what we can do, and we help you to know what we can do. If that. And I don't know if this. I've got brought some packs.
She's a
because
fountain
I'm
of
part of Dementia Inquirers, and we won an award last week for our 7 years of work, where we've sort of turned from researchers asking us to help them with what they want to research. It's people with dementia have gone in the driving seat, and we ask the researchers to help us with what we want researching. And it's been 7 years work, and it was recognised last week at the global awards that we won. Well, it's been involved with Caban and all this. It's just great to be asked and be involved to say what's important for us living with dementia, and really important to explain to the PhD, is it? Yeah. PhD students that are going into that career of dementia, that they understand. I know you need the textbooks and everything, but it's really important that they understand from on the ground the lived experience of a person with dementia. And so thank you.
We just got 5 minutes left.
Yeah,
So sorry. I completely, absolutely agree with you. I think that as a researcher and a PhD student, it's invaluable having someone with that lived experience. It really grounds you in what's important. And that's why I think with this project, we really involved you in all the different stages, and we have to make sure that we go through different things. I should go on to my next slide. So just very quickly, what we have done for this project. So I've kind of broken it down into what I consider to be really 3 things, which is working together, learning together, and creating together. So we've done lots of workshops, exploring resilience and dementia, literature reviews and interviews with people living with dementia and family carers. I'm just very quickly whirling through. And interviews with professionals. And so
can I just say, I'm just reading the learning together.
Yeah.
I've learned a lot from the professionals as well, that about dementia as well, that we're not told to diagnose some of the symptoms. So.
Yeah, I think it's really interesting because working together, you learn from each other, don't you?
Yeah,
and
it's a two-way thing.
It really is. And I think one of the benefits of having someone that doesn't have an academic background as well is, as the research student, you really have to understand the information. So, for example, with grounded theory methodology, you have to really understand it well enough to explain it to someone else who doesn't have that academic background and that knowledge. So you actually really get to learn it well, and try and present the information in different ways, which is invaluable skill really to learn, that you've taught me and helped me with. Working together. And you've done so much, haven't you, on the project, like refining documents, piloting interviews, and we've gone through the results together. And when I've talked about I'm interpreting it this way, you and Anne have added in about, oh yeah, well, in our experience, actually that really makes sense, or you've added things. So it's just been invaluable, really.
Added things, told you to take some things out.
Yeah, absolutely, yeah. So I think that it's been great because you have been very much like my academic supervisors as well, which do exactly the same. They input in different ways and they all add these different dynamics. So it's all about working together. And as a student, you get so much from all the different people with their different skills, all together and working together, learning together and creating together. Yeah. So just move on to my next one. So these are just a few of our reflections then about the things we sort of felt were important. So keeping in regular contact. I know we've said before, Dory, that sometimes when you're involved in research, you can feel a little bit like they're draining you a bit if you don't get that feedback of what's happened with your input, especially with the PPI side of things.
You always, if you're helping in research and then you don't get the feedback, you can feel like a tick box. exercise. So it's important to get the feedback on and keep in regular contact.
Yeah, so it's something to be mindful of, isn't it?
Yeah.
And I think actually when you come right to the very beginning of when you're picking someone that you're working with, make sure it's someone that you get on with, really, because I think, I was lucky enough to know Teresa, in advance, and like you were saying before, she's just she's a dementia activist, really, aren't you? You're involved in everything.
Dementia give me a voice.
Yeah, but that's brilliant, because that means that it is this relationship that works both ways, doesn't it?
I'm just passionate to, maybe too late for me, but maybe not, but for future generations to change the perception and the assumptions of people with dementia. And it's, what we can do, and if you don't think, just ask us and we'll tell you.
Yes, yeah. So I think when you're getting together, then some of the things that we think are important is making sure that you are led by the person and recognise if there's any needs. So we have the I want to speak cards, don't we? That are helpful. Yeah,
really helpful.
Thinking about the length of meetings as well. So I think that's something that we found is sometimes we would get very carried away and have very long meetings, and I think you felt quite tired afterwards, and I remember, and I certainly did as well.
Especially on Zoom.
Yeah,
I think an hour, is enough. But if it needs to be longer, then to have a break, which I find, all the things I've been involved with in Bangor are really good at that, and travel, make sure all your travel requirements are seen to.
and I think as well, just making sure that you really recognise, the time that's input, and really sort of value those contributions. So, giving that feedback to make sure that, like people know how you've changed things in response to what they've said.
Yeah, that's really important.
So we've got a few key messages that I think that we sort of want to make sure that I think we have touched on a little bit. So you've already said, haven't you, about how your involvement makes sure it's really grounded in real experiences. People with lived experience need to be involved. We all need to work together, don't we?
But it gives, apart from helping you, it helps us. For me, speaking for myself, it sort of gives me a purpose, because you get diagnosed. I was 59, and it's doom and gloom, really, and everybody starts doing things for you and you just become invisible. So doing this, being asked to contribute and overlook research, makes me feel valued again. I'm not just a burden. And I'm not academic at all. I was a landscape gardener, happy in my wellies in Spain. And I'm now, with the dementia inquirers, I'm now down as Teresa Davis researcher. Who'd have thought? Thanks to dementia. and having been given the opportunities to do that, and not just be left sitting in a corner and letting the dementia take over.
And I think that from a research point of view, you're just an inspiration, and you encourage me all the time, which is wonderful. And, as I was saying before, I think it really facilitates that understanding that you have to have. You know, and I've learned so much just from your experiences and everything that you contribute. And the same with the Caban group as well, you know, when we have our discussions, just people's experiences are invaluable when you get those different perspectives. You know, and it makes the research real and practical, doesn't it? And important and relevant, as my slide said.
But we're all unique and wonderful.
Yeah.
Together, we're a masterpiece.
Lovely. That's a lovely quote, isn't it? You can quote her. So this is Dory. The clownfish is me. And just to, that's if you want to follow Dory on Twitter, she has some fantastic things that she tweets about. And if you have any questions, I think that's us. I don't know how much over we went, sorry.
Very much. Like questions, so while you're there, that's okay. Has anybody got any questions?
Well, yes, I heard that it's not all in the mind, that the gut has some kind of contribution towards it. I don't know if there's any research being done on that. Because we've got two brains, our brain and our gut, you know, so I don't know much about it. I just read about it.
Brain cells in your gut have the same receptors as the ones that are in the brain. It's really, really interesting. I don't know enough about it, but I know the connection. There is, yeah, and hence the. I thought you get a good feeling.
Did you hear that in Swansea and online? Did you hear that? The question? Hello? No, unmute yourself just to tell us if you heard the question or the comments.
I just wondered about the I want to speak cards because they sound really interesting. I've never heard of them before.
Yeah, I think Marie is looking for some.
There's some in the packs I brought.
So they're a yellow card with black writing that says I want to speak.
Speak, please.
Yeah.
The reason behind them was, especially in meetings or groups, the person with dementia may want to contribute to the conversation or the topic, but if they don't get the chance to say what they want to say at the time, it goes off into the fog. And so we developed these I want to speak cards so that, I mean, they're good for everybody, but if you know there's the person there with dementia, if they hold up the card, give them the priority to say what it is they need to say. My son-in-law wanted one as well.
Just put it to the camera.
That's brilliant.
Okay, thank you very much. And any other questions? No? Right, I think at this point we'll just have a bit of a wiggle because, you know, we said it's been a bit of some people then we go.
Oh yeah.
Thank you very much. So lovely. So the question that came from the floor, just in case you didn't hear it online, was what's the connection between the gut health and the brain health? And one of the responses from the floor as well was that we have brain cells in the guts. Yeah.
I don't know if it is connected, but since I've had dementia, I've become gluten and dairy intolerance.
Oh.
So I don't know if that's the brain and the gut. I've had to cut out gluten and dairy.
That's a really interesting point. And if anybody online thinks that they could share any research that's in that area, or maybe potential researchers in the future, get in touch with us here at CADR, and we'd love to explore that a bit more, because obviously it's not an area that we're doing at the moment, but that doesn't mean that we should do it. Yeah, lovely. Okay. Our next speaker is another of our PhD students here, Maria Caulfield. Her PhD research is an original contribution, which is what the aim was, yeah? And that's what we want everybody to aspire to before they finish their PhD, to have an original contribution. To support the implementation of UK national policy commitments to unpaid carers. So we've talked about caring earlier, and this focus has been a really interesting approach to actually look at different perspectives for unpaid carers. So the policy for unpaid carers, specifically to have a life alongside caring through meaningful short breaks. Now, Maria will tell us a bit more about what a meaningful short break is in her research. Her research needed for this to be built and sustained on constructive relationships between the professionals and key stakeholders. We hear the term stakeholders quite often. It's a jargon we hear a lot. But who do we mean by that? Again, we'll have that focus on unpaid carers and practitioners and commissioners. Just as Dory was saying, we all need to be working together, which is the focus of this seminar. So together as a team, again, they explored what a meaningful short break means and what it can look like or could look like in the future when we actually co-construct, when we work together to help guide social care practice and policy development. So Maria's taken quite a lot on to do in one PhD to sort out that, but she's coming to the end of that journey. So we're sort of really looking forward to hearing about your presentation now, Maria. And after that, we'll have a recording by another Maria. That's Chris or Maria.
Hello. So, hi everyone, I'm Maria and I will be talking to you a bit about the research I've been doing over the past few years, looking at co-creating meaningful short breaks for carers, supporting a family member living with dementia. So just a few notes on terminology. Obviously, in the context of this research, the carers that I've been working with have been unpaid family members, spousal carers, so husband or wife, supporting their partner living with dementia at home, and they've all been living here in North Wales. Just as well, clarity around what a short break means, because obviously some of you may be more familiar with the term respite, which is still used interchangeably with the term short break, and that's fine. But respite can sometimes be used to refer to a service or a respite service, or also as an outcome. So one of the outcomes of having a break away from caring is that sort of respite feeling. But historically, there's some negative connotations around the word respite, sort of associated with the sort of the burden of caring and want to sort of escape from that caregiving responsibility. So we've chosen to, for consistency, I always refer to a break away from caregiving routines or responsibilities as a short break. And a short break invites a more sort of a broader, more holistic perspective of what a break away from caregiving routines and responsibilities can mean. It doesn't imply separation between the carer and, in this research, the person with dementia. So it could be a breakaway together in a different environment or setting. And the purpose is to support not only the health of the well-being of the carer and the person with dementia, but also important caregiving relationships. And short breaks as a form of sort of preventative support is really unique in that it ideally is there to support and sustain caregiving relationships over time. So as circumstances and needs and preferences evolve, short breaks are there to sort of buffer that relationship through all the different changes in circumstances for the family or the couple. So I just go back to the overall aim. So quite a specific aim, but essentially what we wanted to do through this research was to provide a more sophisticated understanding of the short break landscape here in North Wales. And as I just mentioned before, as a form of support, short breaks are essential. They're very highly requested and very valued by carers, and having that unique capacity to support healthy caregiving relationships over time. But the research from the UK, published in the UK and also worldwide, has evidenced a huge amount of challenges for carers in terms of accessing short breaks. There's a lot of research showing that there's not much flexibility, very limited choice, it's quite unsatisfactory experiences in terms of the different models of support, and very inconsistent and modest outcomes supported. So there is that paradox, sort of contradiction there in terms of it being a really needed and essential form of support, but also the experience and the outcomes supported are quite poor. So we, as part of this research, one of the objectives was to take a more sort of nuanced and detailed exploration of some of those factors, and really getting to understand how we can provide a more sort of nuanced understanding of the landscape here, so we can have that evidence to support the better commissioning and delivering of short breaks that actually make a difference to people's lives and well-being. And another objective was to delve a bit deeper into what a meaningful short break means from the carer's perspective. So what does a break look like to them? Is it a physical break somewhere different? Is it a psychological break? And to understand how some of their needs and preferences for breaks evolve as their circumstances change. So yeah, a broad aim with a number of objectives, but I've just highlighted here because of the importance and the significance of short breaks to sustainable caregiving relationships. The Welsh Government has made supporting a life alongside caring a key priority for them in the strategy for unpaid carers, and also up in Scotland there's some really innovative work about trying to evolve and expand what we mean by a short break, and really look at different models and creative models of supporting different breaks. And also in England as well, there's a lot more funding which has been ring-fenced for short breaks. So it is politically an important subject, which globally as well, a number of countries, more economically developed countries, are really recognising the importance of short breaks, of the sustainability of caregiving relationships. So to how we wanted to approach this research, obviously we needed the insight from people working within a range of short break organisations, from local authorities to different carers charities and dementia charities. We also wanted to talk to carers who had experienced a break. There was 4 phases to the research project, but 3 of them involved sort of sustained engagement with different people. So the first phase was interviews with professionals and practitioners, from gaining that sort of strategic and operational insight into their roles from a range of across all local authorities here in North Wales and some of the main charities. And we also held a knowledge exchange event, which was the 3rd phase of the research, where we brought together people from different professional backgrounds and lived experiences and tried to reach consensus around what a meaningful short break could mean, and co-create some practice recommendations. But what I wanted to focus on today was just some reflections really from my work with unpaid carers, and these were spousal carers for people living with dementia, living here in North Wales. And the objective of my interview work with carers was to understand their story of caregiving and to explore with them what a break meant for them, and also how their needs and preferences for breaks evolved over time. So how I approached these interviews was sort of reflective narrative interviews, where it was all based around asking the carer to tell their story. And I've just jotted down a few reflections, thinking back on this process. Actually, it was the first time I did this, so it was quite interesting to think now how I would do things differently. But obviously, what's been echoed before was this: that when I started the study, it was in the midst of all the lockdowns, and obviously I had planned to go in person to some support groups and talk to people in person, sort of introduce myself, but everything moved online. And I did feel it took me, I think, the best part of a year to recruit, well, not to recruit, but to find 13 people, 13 carers who were interested in talking to me about their experience. So it was a lot longer than I had anticipated. And the first support group I went to, they had like a Zoom support group, and the organizer said to me, look, the carers are really exhausted. They're just research fatigue. They get asked every other day for their experience, and what they're reporting back is they're telling people, this is what I think, and they don't see a change. And also, you know, these times now are quite protected for them because it was in, you know, during the pandemic, and they wanted to talk about things that were important to them. So I think that was my first attempt at trying to sort of engage with a support group. And I did feel a bit on edge as I was going forward then in terms of approaching different carers groups, because I sort of felt a bit like I was piggybacking on their time or sort of hijacking their personal time, and also asking about how they experienced breaks during COVID-19 probably was it wasn't the best question at the time. So I think that just what highlighted to me was, if I was to do this again, I would really want to have a very, very clear recruitment strategy on who I would contact and how I'd go about doing that. So obviously there's three main carers charities here in North Wales, but I think there was only one carer that they recommended to me because at the time they had lots of other priorities and dealing with more important things. So I think as a researcher, that just made me think, okay, if I was to do it again, I would want to take more time to think about how I would trying to sort of approach people and trying to find that diversity of carers as well. But luckily, you know, 13 great people were very enthusiastic and wanted to talk to me. And one of the things that I thought was really interesting was I did think, oh, you know, I won't be able to talk to them in person, because that was one of the options I would have liked to have given the carers, is a choice in how we met and how we had the conversation. But it was limited to either Zoom or the telephone. And most carers actually wanted to speak over the phone. And I think that did provide them an extra layer of sort of security or comfort. And one lady was like, oh no, I much prefer to talk over the phone. I don't have to do my hair. And the other gentleman said he was in the conservatory and he could see his wife, but was able to relax and still talk on the phone. And someone else was poaching a chicken or something while she was on the phone. So it was actually, I did think it would be a challenge, but it turned out to be, you know, quite a positive experience. And as a researcher as well, as I was aware of, I only had a certain amount of time to do these interviews. So I got to get, it was more time efficient for me. So it wasn't all a negative experience. And also asking the carer to tell their story. I think the simplicity and about just asking them, tell me your story, worked really well, because as sort of Graham alluded to before, it really it allowed them just to talk very freely and unguarded, and often they went off on sort of tangents, but I was able to sort of focus the conversation back. So that was quite a positive experience. I didn't ask too many why questions, because I think that's a temptation to do, is sort of, why did you do that? Why didn't you do that? But I didn't want to sort of undermine their approach to caregiving, or sort of, sometimes you could, you didn't want to sort of question their judgment or their sort of moral compass. So that was important in narrative interviewing, the technique. You don't sort of probe why, you sort of let them speak and talk about what's important to them. Obviously, the interviews were quite emotive, and it did bring up some upsetting reflections, and that, as a researcher, that was important, that I was able to allow the carer time to pause, and one lady sort of switched off her camera off and on throughout the conversation. And I also wanted to demonstrate to the carers that they were also part of sort of a broader, wider community here in North Wales who were interested in their personal experience. And one way that we tried to do with this was invite them to this knowledge exchange event, where they got to meet other professionals working specifically to improve access to short breaks, and where they got to share some of their experiences and their opinions. And we sort of discussed that in a hybrid event. So that was important to me, that all the carers who took part in the study were at least invited, and somewhat did attend online and in person, to show that they were part of something bigger, and their research actually wasn't just a one interview, it was being talked about and embedded into a larger programme of work. I think that's everything. Yeah, so do I still have time? Yeah, sorry, I haven't missed anything. So I'll just show you some of the, so this model was a descriptive model of the short break landscape that we, through the interviews with professionals and practitioners, that we tried to develop. And we tried to interpret some of the main challenges and opportunities to commissioning and delivering short breaks. It'll take a bit of time to explain, but it was just my interpretation of trying to represent the landscape visually. And we sort of talked about wider contingencies, which are sort of policy and political directives, some of the focal contingencies, which are relevant here to North Wales, particularly around regional collaboration, which is broader work as part of the regional partnership boards. We looked at work within the community about building dementia inclusive and caring and supportive communities. And we talked about some of the factors that underpin and support a meaningful short break. So that was a model that we created with the professionals. And this is a sort of a collective narrative of the caregiving career sort of trajectory that emerged through some of the work with carers. And this was about how their needs, we tried to map sort of the caregiving career, and also how their needs for breaks and preferences for breaks evolved over time. And these were just some of the sort of the key turning points or transition points that I plotted. And around those points, there's certain themes that we talked about in more detail. So we could, at the start here, the carers reflected on their life following diagnosis. There was a very gradual progression in symptoms, and things obviously didn't change immediately. They were still very much husband and wife and a couple, and sort of navigating the normal routines and challenges of their life. And then as sort of time progressed, things, circumstances changed, and how the dementia presented as well changed for different couples. So this was sort of a one representation of how we tried to map that change over time. And just a few factors that we found underpinned what a meaningful short break meant to the carers in this study. It was having a choice in breaks that reflected what mattered most to them. So again, that person-centered relation-centered care, and how that was embedded sort of into the short break experience. It was having a mutual benefit, and I think that stood out to be quite an interesting point, that a short break inherently is a relational support. It was just as important to the carer that the person with dementia had their interests and strengths and capabilities supported and nurtured. And if that wasn't the case, then they couldn't have a break. So it was very much an interpersonal negotiation and navigation about what support suited the couple rather than just the individual. Consistency of the care staff supporting the break, that was really essential. So those trusting, caring partnerships, and that comes back to, again, wider issues maybe about the care workforce and the well-established problems there in high staff attrition, etc. Flexibility, there's a lot of great work going on about how to provide more flexible provision, and some of that's been really pioneered by the local charities here in North Wales. Planning a break is still very difficult because of lack of resources and the unpredictability. Sustainability, that comes down a lot to the funding, and the funding is mainly, it was a 3-year funding, a lot of it through the third sector, but now there is plans for at least a 5-year sort of window of funding, which they're trying to make it more long-term and sustainable. And also appropriateness of break length and frequency, and that terms of appropriateness to a stage of dementia and stage of caregiving formed the 4th part of our research, where we looked at how we did a literature review around different stages of the caregiving career, and we tried to map how different breaks were most appropriate to different stages. So that's some of a chapter of the thesis that came out from a more sort of detailed inquiry about what a meaningful short break could mean. Okay, I'm on time.
Very much, Maria. That was brilliant, and as you can appreciate, it's been a big job, and you're coming to the end. For those are PhD researchers, there is hope at the end of the tunnel. You can still be standing at the end and very close to the end now, Maria. Any questions in the chat now? So I think there was a question here. Did you identify the differences between carers who had or had not had a carer's need and assessment? And was there any evidence of local authorities providing funding through the direct payment system to fund short breaks? Also, did the issue of backfill care get raised by John? John's brilliant at asking questions today. Thank you, John. But I don't know if you can approach that.
Yes, definitely. So the carers assessment and the process of the carers assessment and how that's conducted and what's discussed was really essential to the findings. And I've talked about that a lot in as I've written up, because obviously accessing a break, one of the main routes to accessing breaks, particularly that require formal support from social services, is through a carers assessment. But the research on, the evidence around carers assessments and how often they're had and what's discussed and who, the formality of that process, and also the value and the merit attributed to that process is hugely variable across North Wales, and I suspect further afield as well. So how carers get to understand what options they have for them in terms of accessing a break, eligibility around, are you eligible for different services, do you have to pay, breaks offered through communities and the third sector. It is a minefield, but from the carers I spoke to, having a carers assessment was not a regular engagement, I think, and the prominence of a short break in that assessment process wasn't very strong. So I think there's more that could be done to discuss the importance of short breaks during the carers assessment process.
Plug. In the Knowledge is Power booklet, you can find out more about all the carer support as well. And that's co-created by people through lived experience in sharing what's important. So access that booklet if you want to find out more.
Yeah.
Thank you, Maria. Is there another question?
Just direct payments, definitely as a form of trying to provide more flexibility and creativity in how a break could be supported. Direct payments was definitely discussed, and I think a lot of work is going on to streamline how direct payments are managed and can be supported locally within the local authority. So that was quite a positive finding from the research, that it definitely gave people a lot more flexibility in how they wanted to experience a break.
Great.
Yeah.
Thank you, Maria. Lovely. Now for our last speaker, we've actually got a recording by Maria Cheshire Allen, who unfortunately couldn't be with us today, but is follows up really nicely from the work with charities that Maria was just speaking about now. So we're just going to have this recording by Maria. I think it's about 10 minutes. And then after that, we'll just have some closing comments by Professor Jill Windle here. And if you've got any questions following on from the session after today, do get in touch with us and we'll pass on the questions to the researchers or the academics involved in today, or indeed the people with lived experience who are actually leading their own research studies as well. So thank you to Maria, although she's not able to be here. We'll just listen to Maria's talk next.
Hi everyone, I'm Maria Cheshire Allen and I'm a postdoctoral researcher at the Centre for Ageing and Dementia Research at Swansea University, and my research interests lie in unpaid care, ageing and social care. I'm also a volunteer at our local carer centre here in Swansea, and I'm also an unpaid carer. So I'm really grateful to Diane and the team for inviting me to talk to you today about how my research involves carers. I'm sorry that I can't be there today. It looks like it's been a great programme, and I'm sure you've all had some really worthwhile and interesting discussions so far. So in this presentation, I'm going to give you a quick overview of what my research is about and the broader context in which my research is located in. And also tell you about some of the things that I've done to involve carers in my research. So to begin, and firstly to locate the research within the broader context, so my work is focused on the well-being of unpaid carers. So we know in the UK that we are living, many people are living with chronic ill health, and care needs are growing and becoming more complex, and there is significant evidence of unmet needs. And this is part of a broader mainstream narrative that describes the care crisis in the UK. And situated within that crisis narrative is the unpaid carer. And most care provided to people is provided by family or non-kin relations and unpaid carers. And in Wales, we have 310,000 people, that's 10% of the population that identify as an unpaid carer. So that's a significant portion. So my research is looking at how we can support carers to experience better wellbeing outcomes and within this broader context of the care crisis. So in the presentation today, I'm going to give you a quick overview of some of the actions that I've taken to involve unpaid carers in my research. And I thought it might be helpful to offer examples from the different stages of research of how I involve people at both the development stage and also give you an example of how I've involved carers in actually the delivery of a research group. So there's two examples. There's delivering innovation in social care. That's my DISC project. and that's my fellowship application that's currently going in under review. And then there's the Care Research Interest Group, the CRIG, which has actually received funding. And part of this, I think, is crucial to involvement is reflection. And I'll just give you a few of my sort of insights and learning from both of these projects. So I'm absolutely committed to involving carers in my work. This is something that I've been doing throughout my research career, and recently as a volunteer at my local carer centre, I've seen firsthand how involvement in research can make a difference, not just in terms of service delivery, but also in terms of the impact on the carers themselves and their families. So it's something that I'm really passionate about and really committed to. So alongside all this passion and commitment, I also follow something called the UK Standards for Public Involvement. And these are sort of the standards, the gold standards really governing involvement of people in research. So my projects are always referring to and guided by this good practice and these standards. So one of the key aspects of involvement is timeliness and making sure that people are involved from the start at the priority setting and design stage. And my initial grant for in being able to involve people in the priority setting stage was an initial grant awarded to me by the Research Wales Innovation Fund, WIF. And this enabled me to spend a few months doing some engagement activities with people and specifically carrying out some focus groups with carers. So I carried out 4 focus groups, asking them about this research topic, what the research aim should be, and specifically whether they felt that the research could have a benefit and be impactful to them and their use of services, and particularly the third sector. One of the main outcomes from this has been an acceptance of the research into a research paper, the Journal of Social Inclusion, and my co-author on that paper is an unpaid carer, and she'll also be presenting the findings with me at various conferences, and also we're doing a podcast. So that's an example of how you can, even at the design and priority setting stage, still find a sort of research output and meaningfully involve someone who's representing sort of lay people, in my case unpaid carers. I also drew upon CADA and their research associate network, and they inputted into the lay summary and plain language summary of this project. So in terms of the delivery and implementation of this project, if it was successful, the main mechanism in which I hope and intend to involve unpaid carers is through a research advisory group. I'll continue to co-author and look for opportunities to tailor and deliver materials based on the outcomes of the research, and look at lots of different ways of involving people. I've included quite a budget heading, and you're encouraged to do that and make sure that you really think through exactly what you need in terms of training, resources and money. And I've also drawn upon the expertise and infrastructure from involving people. So looking at a sort of grant that I've received funding for, this is the Care Research Interest Group, and I received a research network grant from the Learned Society for Wales. And this grant really is enabling me to bring together all different stakeholders across Wales, academics, unpaid carers themselves, policymakers and practitioners, and we're all coming together as a network. We've come together twice now to really discuss and share what the priorities for research on unpaid care should be in Wales, and that's been a really worthwhile sort of network that I've established with that CCON funding. And part of that network are Carers Trust, and they're a co-applicant, so they're a national non-governmental organisation working directly with and for carers in Wales. And 3 unpaid carers are members of the Care Research Interest Group, and their input and insight is hugely valuable. I recruited them through CADA, who have got an extensive network of research advocates, and also through the Involving People network. And there's certain processes that you can go through to ensure that quite a diverse range of people are sort of recruited and involved. There's loads of good practice around this. And again, if you go to Involving People or the standards, then you can find lots of resources and help there. So I'd really refer everyone onto those. So some reflections on all of this work and my experiences of it. It's all about being very much outward focused and making sure that I'm connecting with people who my research aims to benefit, and that is ultimately unpaid carers and their families and the organisations that they represent. So key is developing relationships and communities. So that can be quite time intensive, but it's also really rewarding and can be really interesting aspect of the research process. I definitely recommend trying to submit grants. Again, they can take time, but if they can help and support you in developing your involvement work, really in trying to develop those sort of networks and those relationships, again, it takes a lot of time, and if you can get some support to be able to do that, then again, that's one of the key things that can really help you along the line. Gaining feedback, both from unpaid carers themselves in my case, also on the organisations that they represent, just you know, really listening to feedback on how they feel their involvement has been valued, has impacted, can be really important part of the process. And I think it's critical. And asking for feedback, you'll also get to hear about the broader impact of being involved. And overwhelmingly, I have very, I'm like, you know, generally very positive things people say to me about being involved in the research. Things like getting a confidence boost, doing something different beyond their caring role, and they feel like they're doing something worthwhile. Also, having these conversations and really creating time for them ensures that sometimes you can hear about other things and you think, well, that sounds like you could do with maybe a bit of support. So I can sign, and I often do, signpost people onto specialist organisations and services. They might mention that they need something, and I think, well, it sounds like you could, you know, go to the local care centre. They're the right people. They'll be able to find out. So you can help people in lots of non-research ways through your research, and again, that is really, really rewarding and an important part, I think, of the process. Draw on the expertise, support and resources. So same again, really, there's tons of information out there. There's lots of expertise, particularly in Wales. And I think, you know, there's, if just reach out and get draw upon all this experience. So thank you very much for listening. I hope that was helpful. There's a couple of websites there that refer to the National Institute for Health Research Public Involvement Standards, and also the Healthcare Research Wales Involving People Network. Thank you.
Well, I think we should all clap anyway. Thank you, Maria. That was great. Right, so start my video then. Okay. I can't. Okay, lovely. Thank you, Maria, for that lovely summary and reflections on what could be useful for other researchers and people working alongside. That brings us quite close to our aim for finishing at 1 o'clock. So I'd like to thank all our speakers, but there's two things I'd like to do at the end now is ask everybody who's online to access the link to the evaluation form. Make sure that anybody here in Bangor will be actually having some sandwiches to fill in an evaluation form before eating, otherwise you'll forget. And then also I'd like to ask Professor Jill Windle just to give us a few closing remarks as well. Diolch yn fawr.
Thanks, Catherine. Hello, Swansea. Well, I've been scribbling away while I've been listening to all those really, really interesting talks. So I'm going to try and be as quick as possible because I realise we've gone over time and we're probably all really dying to get to that lunch that's out there. So just a few things that came to mind as I was listening to all these really fascinating talks. What we've heard about is a lot about the process of doing the research. And, you know, we've heard about some of the challenges that people have faced. Graham was really honest and said he felt out to depth at times. And I think that's something that faces all of us, regardless of what stage of your career that you're at. We all have those moments when we feel really out of depth with what we're doing, but we learn from it and go on to the next step. And I think also, you know, one of the big challenges to Bethan, Hannah, Maria, was the COVID pandemic and how people had to really adapt quite quickly in terms of what they were doing. In terms of Bethan, I think it was a new project, wasn't it, completely? But others had to think about the different approaches that they took when they were doing their research. And again, you know, some of the speakers are very honest and talked about how they were really inspired to do their work from their own personal experiences, which was really nice to hear. And all have had this real, almost like a very collaborative approach in their research, haven't they, where they've been asking their participants about their own personal experiences. And Hannah's really, and Teresa really brought to life how involving somebody with that lived experience can both benefit the research, but Doris also feels like she's now a researcher. She is a researcher. You put yourself, I think I wrote down what you said. Yeah. You put yourself in the driving seat and you said it made you feel more valued now. So that's, you know, positive benefits all around there. And then Graham had this real challenge around the rural development side of things. How do rural communities support us to age well? And I started thinking, well, what do we mean when we talk about rural? What's the definition of rural? And that's something that as research catches researchers out a lot. What do we mean when we mean rural? In Wales, we think about rurality as being so certain distance from a hospital or a shop in perhaps a few miles. And we think about places like Canada. They may be 100 miles from a hospital and have to get a helicopter. So it does really challenge us to think about what we mean when we with some of our definitions. We've also had some really good tips from Hannah about how to actually involve people with dementia in your research. So the good bullet point list of how to do it well. So thank you, Hannah. Just trying to read my notes here. And we're also carers. We had 4 projects that were really looking at the experiences of carers, just really highlighting how important this area is. And I think Bethan, we're looking there with the iSupport project. It's about an online resource. So there will be groups of people that aren't online and won't access the benefits of that. We can counter that by making paper copies available. But, you know, as technology advances, as the world advances, we get more and more digitally focused. And it does raise this question of digital exclusion. And in Wales, there's a lot of digital exclusion, not only because of people who can't or don't want to use technology, but because there's big areas which has no coverage, there's no broadband coverage. So how do we get online? And I think also there's another big point that I started thinking about was the representativeness. And Graham and I had a discussion around that in his presentation. When we think about the people, we have a best sampling strategy in the world when we want to recruit our participants. But the reality is it's very difficult to get people to take part in research. So how do we really get those people whose voices aren't heard? Perhaps the people who live in deprived areas or in poor health. Those are the people that we want to represent equally in our work. So it's a big challenge to all of us, and not just for PhD students, but for everybody, because it has implications then for what your work means at the end. And again, you know, the impacts of your research. We've got some projects here that have got some really applied focuses at the end, which was lovely. You know, Maria's established a carers research network. Hannah's got a resilience building framework. Bethan's got a website specifically for carers, people living with rarer dementias, and Maria's going to be informing commissioning and delivery of short breaks. So some real applied focus there, which is lovely. And I think that's probably, and we have a new word. Peeving. So that's something to take away. And also, one thing I picked up from Zoe's talk was if people are having incontinence issues and they're not getting anywhere with their GP, is to ask for a referral to an incontinence nurse. So that's a really good tip from that today that I didn't know that you could potentially do. So thank you, Zoe. So I think that's it, Katrin. Thank you. And thank you, everybody.
Yes, so it's a challenge to summarise 3 or maybe 7 years PhD into 10 minutes, isn't it? And I think we've done a fantastic job to have such a broad range. And I'd like to thank everybody for your contributions and hard work. And thank you, Jill, for doing a great summary of the highlights from this morning or this afternoon. So there will be the recording